Cheryl, and we created this podcast as the Adult Leadership Advisory Board, or ALAB. Who we are in terms of ALAB is a group that focuses on issues, challenges, and difficult topics facing our community. We are working hard to develop educational programming, social tools, and fundraising initiatives to inform, include, and support adults with cystinosis, but ultimately anybody in our community, our friends, our families, our neighbors, and anybody that might or might not be affected by cystinosis. We, as the Adult Leadership Advisory Board, are funded and work under the Cystinosis Research Network. For those of you out there who might not necessarily understand or know what cystinosis is characterized by the accumulation of the amino acid, or one of the amino acids, cysteine, within the cells. When the cysteine builds up in the cells, it often forms crystals and will sometimes attack certain organs and tissues, predominantly the kidneys, but also includes the eyes, muscles, thyroid, brain, pancreas, and testes. Previously, it was known that an individual born with cystinosis would not live past 10. It's pretty grim, and I'm sure many families out there were quite devastated when they had a newborn who was diagnosed with this disease, cystinosis. However, today we have members in our community living well past 50 years old.
Hello, Cystinosis community. Welcome to the third episode of our new podcast, Cystinosis Rare, A Journey into the Unknown, where we will be discussing transitioning from youth to adult care in the medical system and many challenges we face. Our mission for our podcast is to bring a voice and inspiration to the cystinosis community through real stories and education from medical professionals and individuals living with cystinosis. We are lucky enough to have two special guests joining us today, Dori Rivera, a patient access manager, and Dr. Paul Grimm, a pediatric nephrologist. Let me first introduce Dr. Paul Grimm. Dr. Grimm is a professor of pediatrics at Stanford University. He received his MD with distinction at the University of Saskatchewan, Canada, in 1981. After serving as a family doctor in northern Saskatchewan, he completed his postgraduate training in pediatrics at the IWK Children's Hospital in Halifax and the Winnipeg Children's Hospital in 1986 and completed a pediatric nephrology fellowship. He went to UCLA for further training in transplantation immunology, finishing in 1991. Dr. Grimm returned to Canada, serving as assistant professor of pediatrics at the University of Manitoba until 1999, when he was recruited to UCSB as associate then full professor of pediatrics and medical director of pediatric kidney transplant. Recruited to Stanford in 2007, he was authored 90 peer-reviewed publications and is the recipient of numerous honors and awards, including a listing in the Best Doctors in America from 2002 to 2020. He serves as the medical director of Stanford LPCH Pediatric Kidney Transplant Program, medical director of the Cystinosis Referral Clinic, and director of the Pediatric Nephrology Fellowship Program. He is also currently a member of the medical advisory board of the Cystinosis Research Foundation. Dr. Grimm met his first patient with cystinosis in 1983, who was actually the first Canadian to be treated. Since that time, he has cared for more than 100 cystinosis patients and their families, mostly through the Cystinosis Referral Clinic and ongoing research. Thank you for being on our podcast, and welcome, Dr. Grimm.
I'm delighted.
We also have Dori Rivera with us. Dori is a patient advocate and mom whose daughter has an ultra-rare disease called NOMID, and who is also a professional in the rare disease space with a wide range of experiences working in the healthcare. She has worked for the state of Illinois' Department of Health and Human Services as a senior health policy advisor, working alongside more vulnerable populations and people with chronic health conditions. Dori currently works in the biospace for people with rare diseases with Horizon Therapeutics as a PAM, as a patient access manager. She has played a pivotal role as a parent at the NIH, National Institutes of Health, serving on several committees and councils. Currently, Dori serves on the board of the ARC, She, along with other moms, started a nonprofit for the auto-inflammatory diseases like her daughters. Dory is the Vice President of Public Policy on the board of that nonprofit. In her free time, she volunteers at a wish granter for Make-A-Wish and enjoys spending time with her daughter, Kayla, working out and traveling. Thank you both for being on our podcast. We are honored you sharing your experiences to help the community today. We have gathered a few questions from the community to ask you both about transitioning from youth to adult care. Question number 1 is for Dr. Grimm. Are there any tips or tricks you have when it comes to talking about cystinosis and transplant with a new doctor?
So when people move from the pediatric world to the adult world, it's really hard. You know, the pediatric world you've grown up in, and it's been cozy, and you have a relationship, you and your doctor and the coordinators or nurses or physios or nutritionists. You've got a whole family there. And as part of growing up, you have to leave your family and strike out on your own, and whether it's your own family that raised you or whether it's the family of people that provide care for you. So this is just a natural part of growing up. So when you're meeting a new general doctor, the way I like to think about it is going on a date. You know, this general doctor isn't necessarily the one that's going to meet all your needs, and there has to be a relationship between you and the general doctor. So sometimes you have to try a few before you find one who's interested enough in you or interested enough in the disease for you to really sort of say, okay, this is the one, at least for now. So think about like when you're going on a date with someone for the first time, what you may want to do is give them a small package story of your life, you know, like what they talk about an elevator speech, you know, so like a 5-minute, okay, this is who I am, this is my disease, these are the things that have happened to me, and now I'm a college student, or now I'm engaged, or now I'm working on my life, and so cystinosis is just a part of my life. Mm-hmm. So that sometimes is a way to sort of meet the doctor and see how they respond to that. But there are sort of some rules of dating, and I think they apply to meeting a new doctor. So one of the things you're never supposed to do is talk about your previous boyfriends or girlfriends, right? You're not supposed to spend the time being critical of your previous boyfriends or girlfriends or saying they were crazy or they were psychotic or they were a stalker, because if you start talking about that on your first date, they're going to think you're weird and they may not want to have a second date with you. It's kind of the same thing with doctors, because they're people too, right? If you're complaining about a bunch of doctors, the doctor's thinking, geez, if I do anything wrong or screw up, they're going to be complaining about me to someone else, so maybe I shouldn't get invested in them. And then on the other hand, if you're just talking about how wonderful your previous doctor was and how sad you are to leave them, they're thinking, wow, you know, I'll never meet up. I'll never match up. So talking about your previous doctors isn't a really good idea. The other thing is, you just have to remember, oftentimes it takes a 5 or 6 dates for you to really know each other and to decide that this is the one you really want to like become, what's the right word, monogamous with, you know, like, okay, you're my doctor now, you're the main one. And it's the same thing with dating and with doctors. So you more information is exchanged on each subsequent visit, and you get to know them. And remember, you know, in our world, the doctors are limited because like they may have 20-minute slots or 30-minute slots. And some doctors are lucky they might have a whole 45 minutes or an hour for a new patient. But you need to understand that if they have only limited time, because there's a patient after you and a patient after that, if they start spending longer than they're supposed to with you, they get criticized by the bosses of their clinic. And also the next patient that comes in is pissed because they're late. And so it's a cascade. And so the doctor is caught. And it's not like they're godlike and they can just say, oh, cancel all my patients for the rest of the day. We want to talk to you. So when you think of what do you want to spend that 20 minutes or 30 minutes talking about? And here's a huge mistake that so many people make. They don't have an updated list of their medications. Mm-hmm. Do you want the doctor to spend 10 minutes talking about what medicine are you on? And you're saying, I think it's lisinopril, lisinopril, Prosibi. What a waste of time. bring them an updated list of the meds, or at least all your bottles. But if you have a list of the medicines with the names and the number of milligrams and how many times they take them, that means that the doctor's going to have all that extra time to actually talk to you and look you in the eyes and learn more about you. So the next thing is you show up with a stack of 400 photocopied medical record pages, right? And you walk in and the doctor looks at the stack, looks at you, hasn't seen the stack before, and has a choice. Do I spend my precious 20 minutes flipping through papers that are photocopied or actually talking to this person in front of me? So if you have a stack, try and get it to the doctor in advance. Now, it's unlikely they're going to be able to go through every single page. And they probably won't. They don't have time. They have a wife and kids or a husband, and, at night, why are they going to spend 2 hours going through 400 pages? But bring the stack anyway, because there might be some critical piece of information. Like you might say, when they put me to sleep for my kidney transplant, they told me I almost died because of some drug reaction. I don't remember what the drug reaction was. Well, maybe it'll be in the stack. So the stack is more like a dictionary. When you bring a dictionary, you haven't read every page. It's for you to grab and say, okay, what's this word? So when you go in, have your 5-minute speech memorized, or having a 1-page or 2-page list of all your operations and all the big things that you can say, okay, this is the shortcut. This is sort of like the real summary. So then you can talk. One thing that I've had happen a few times, and it just turns you off, is you ask a question and the patient says, it's in the file. Why are you talking to me? Look in the file. Didn't you do your work? Well, if it's 400 pages, no, I didn't go through every page the night before the visit because I have a wife and kids. So if I ask a question, and you're thinking, well, it's in the file, you might say, oh, it's here in the file, or yeah, this is what happened. And that'll be helpful. Or you can say, I think it was around this operation. Let's check it out. And then the doc will grab the file, open up and say, okay, here's the surgery. Okay, now I see. Now I understand. So those are some of the things that I would recommend when meeting that doctor for the first time.
I really like those points, Dr. Grimm. I appreciate your honesty. It's all about getting organized and knowing yourself so you can speak to yourself and kind of make things happen a little bit quicker so you can get to know your doctor, and kind of like the dating analogy of it's really about trusting who you're speaking with in terms of in the medical system. So I appreciate that a lot. It was great.
Yeah. All right. Second question for you, Dr. Grimm, is it's kind of a three-parter. Is creatinine number important for considering a transplant or time for a transplant?
Okay. Well, first of all, I know this podcast is not just in the USA. And being a Canadian, I know that in Canada, the units are different. And in the rest of the world, the units are different. And so a creatinine of 1 in America is like a creatinine of 88 in Canada and the rest of the world. So that's the first thing you just need to know when you're thinking about the creatinine, is where you are. The other thing is the creatinine is only an estimate that helps us figure out what the kidney function is. More important than a number is how people are feeling. I've had people where the creatinine number says, geez, we should be transplanting you or putting you on dialysis. And yet they're still an A student and they're doing track and field or sports, or they're doing great. And so they're saying, I feel wonderful. And then you start saying, okay, well, maybe the numbers aren't that accurate because clearly you're doing well. On the other side, especially in the cystinosis patients, sometimes the creatinine number isn't that bad, but they know they're suffering. Their grades are going down, or they used to be able to do certain activities and they just don't have any joy in those activities anymore. Or their appetite's gone down from what it used to be, or they've stopped gaining weight, or they're starting to lose weight. So it's really important to look at the whole patient. Okay, now that I've said that, creatinine is made by muscle and peed out by your kidneys. And the number in your blood is the sort of the balance of how much muscle is making it and how much your kidneys are peeing it out. In addition, if you eat a big piece of meat the night before your blood test, the creatinine will go up in the blood because meat has creatinine in it because it's muscle. And so when you digest that big steak or that big triple quarter pounder with cheese, that can make your creatinine temporarily go up. So there are different reasons why your creatinine might go up. So some people are very slender or babies, and their normal creatinine should be lower, like in America, 0.3 or 0.4, and in Canada, 40 or 45. On the other hand, some people are really active athletes. They're lifting weights, they're running. And I know cystinosis patients who get a personal trainer or make a commitment to working out, and they can really bulk up their leg muscles and biceps and stuff like that. So if you have a lot of muscle, your creatinine will be higher, not because of kidney failure, but more because there's just a lot being made by the muscle. And creatinine itself isn't toxic. It's just a way of measuring it. So it's more the trend. One thing you can do, and there's a link on the podcast website, is you can go to the link to use your creatinine to estimate your GFR. Now, the GFR is the glomerular filtration rate, and that's really what the creatinine is trying to measure. The glomerular filtration rate is how much blood is cleaned by your kidneys as related to your body size. And normal is 100 or above. And as you get old, like in your 60s or 70s, your GFR normally drops. But if you're a younger person, it should be 100 or above. And if you go to this link and you plug in the numbers you have, your creatinine and your height and your sex and your race, and for people over the age of 18, your BUN and your height and your weight, you plug those all in, and it gives you a number. And the GFR number is better than the creatinine to really understand how much kidney function you have. And if over time the GFR number is dropping, that means your kidney function is going down. And we start talking really seriously about dialysis and transplant when the GFR number is 20 or less, and especially when it's less than 10. So when your GFR number hits about 20, and it's the same in America or Canada or France or Belgium, when your GFR number hits about 20, you need to have a plan. And that might mean getting a kidney transplant evaluation at your kidney transplant center, looking for a living donor if you have someone, either a close friend or a family member, or making a plan that, okay, we don't have anybody on the living that's a living donor, and we know the waiting list is a long time. So what kind of dialysis will be best compatible with my lifestyle? And start educating yourself. Because when the creatinine number, when the GFR number hits closer to 10, you really have to start doing something or getting ready. So creatinine is a way to guess your GFR number. And by knowing your GFR number, it's a much more reliable way to determine your kidney function. Does that answer it okay?
Yes, that actually answers the other question too, so.
Good job.
Yeah.
Ooh, okay. Bonus points. All right. So the other thing is in different parts of the world, there's sort of different numbers. And also, if you're under the age of 18, you don't need to wait till your GFR number is 20. Your GFR number can be higher than that to be listed for a kidney transplant. But when you're over 18, if you're going to see a kidney transplant specialist for the first time in the United States, the rules are you can't be listed till your GFR hits 20. So you can't start getting waiting time when your GFR number is 20 or less. But if you're a kid, you can be put on the waiting list before that, and you can start getting waiting time. So it shortens the amount of time you might have to wait. For an adult to get a kidney transplant, so you just get started on the list, the average wait in California, where I work, is around 6 or 7 years. So from the time you get put on the list when your GFR number is 20, 6 or 7 years may go by before you can get a deceased donor. So that's why living donors are so much better. And if you can get on the list before your 18th birthday, they can start you gaining waiting time when your GFR number is much higher. So you've had a lot of waiting time by the time you really need your kidney. So there are some real benefits to being seen by a kidney transplant program before your 18th birthday to get on the list, if you have that option. In Canada and in other parts of the world, the rules are different. I don't know the rules that well, but having an open discussion with your doctor, who's your advocate, to see when should I get referred to a kidney transplant center, what's my GFR number, and make a graph. So 2 years ago, my GFR number was 60. Now it's 40. So I lost 20 points in 2 years. Does that mean in another 2 years I'll lose another 20 points? I'll be down to 20? If the doctor says yeah, then you know that in about 2 years you're going to be having to start really looking for a kidney donor or something like that. So the change of the GFR number over time can help you predict what your life is going to look like. And that could be important. Like, am I going to go off to college in 2 years? Am I going to stay home and do community college because I also am probably going to get a kidney transplant around that time? It's important to make decisions like that. And so that GFR number is really good for planning, not just for things like kidney transplants, but where you might go to school or you might go to a job, or do I take that world trip now or do I wait for 2 years? You know, maybe now is the right time. So that can be a real interesting discussion with your docs. Okay, I'm done.
Yes. Okay. So the third question here is for Dr. Grimm. How has COVID-19 changed the way you help cystinosis patients transition from youth to adult care?
That's complicated.
Yeah.
Wow. You know, the hard thing for patients and for doctors is every couple of days, every couple of weeks, every couple of months, the recommendations are changing. So what I recommended 2 months ago is different now, and that drives me crazy. Like when it first started, they were saying, oh, you don't need to wear a mask if you're walking around. But that was really, they were trying to save masks for the sick patients and for hospital workers, and there wasn't enough. Now we have enough masks. They're saying, oh, everybody should wear a mask. But if you're a Republican or a Democrat, people look at it in very different ways.
Yeah.
So this whole mask thing has turned into politics. I went hiking with my family in the Sequoias National Park 2 weekends ago. And that's an area of California which votes quite Republican. Believe it or not, there are Republican areas in California. And nobody was wearing a mask. And like, we went into a pizza place and the lineup was packed and there was no social distancing and very few people were wearing a mask. And I realized how different it is in different parts of the country. But wearing a mask has been shown to do two things. One is you're protecting the people you're around, because the mask reduces the big goobers of spit that flies when you talk. And those are the things that can carry the virus. So why is that important for a cystinosis patient? To be honest, young people don't even know they have it. I have 2 patients who have had kidney transplants who are COVID positive. Neither one of them thought they were sick. And the parents thought that the lab made a mistake. And we only did the testing because we were going to do a surgery. So here you've got a totally normal kidney transplant recipient. We're going to do a surgery. We test them. They're COVID positive. Who have they been spreading it to? Grandma? What if they were a cystinosis patient and they had just come back from a cystinosis conference where there was all sorts of older cystinosis patients, people in their 30s or 20s who've got lung disease or on dialysis? That could have been spread to them, and that could kill them. Because what we know is that if you're a young person and if you're a kidney transplant patient, you're protected, because the kidney transplant drugs really seem to reduce the severity of the disease. But if you're older, so you have bad lung disease, or you just can't cough because you're too weak, if you have diabetes, all those things are the ones that put you in the high-risk group. So the older cystinosis patients are in that group. So I think social distancing is really important, because the young cystinosis patients or their families might not even know that they have it. And if they transmit it to one of our older members of the community who are not so healthy, that could be it for them. But other than that, you know, a lot of clinics are shut down, or they've really closed, or they've gone to telehealth. So if you are seeing your first adult doctor on a telehealth visit for COVID, you know, it's interesting, because, you know, you're not seeing them face to face and they can't really do a physical exam on you. So it's all about the story. So looking into the camera, talking to them about your life is just the same as when you're in the room. And sometimes it's better, because I have patients where they show me their room, they show me the art on the wall, they show me their video game console, because they grab the telephone, like their smartphone, from their mom who was doing the visit. They say, okay, I'll show you my room. And all of a sudden the teenager takes over the visit. And it's awesome, because the teenagers are comfortable with technology. They're comfortable with FaceTime or whatever. And the parents are less so. So sometimes when the teenager would be sitting there letting the mom talk in a clinic visit, they actually are taking over the visit and showing me stuff and getting really engaged. So telehealth with COVID actually is kind of good for some of these patients. So it's not necessarily a bad thing. And having more time to talk actually can allow things to open up. So COVID hasn't been a real barrier to transitioning as long as the doctors are doing telehealth. I do worry for if there are ill people coming into waiting rooms. And so there are some clinics where if you have to have an in-person visit, they'll say, wait in the car and we'll call you. And then you don't have to sit in a waiting room with a bunch of other people coughing and gasping. That's good. Or what they might do is they may have a situation where they're doing some telehealth and some in-person visits. But you may just want to talk to the doctor's front office staff and say, hey, I have these pre-existing conditions, so I don't really want to hang around in a waiting room with a bunch of people who might pass on something. So can you get me into an exam room quickly, or should I just wait in the car and you call? So if they don't offer that, that's a really good suggestion, okay? And the other thing is about going to the ER and blood draws. The thing that has me worried is a lot of patients have been not getting their routine care. They've been afraid to go get blood draws because they're afraid of getting infected by the other people waiting in the lab. And I've had people that really needed to go to the ER and they didn't because they were afraid of the same thing. And I have some patients that really suffered for not getting health care when they should have. So everything in life is a balance. And you have to make decisions that are the right for you. But we are seeing a lot of people who are missing important care right now. And I just wanted to bring that out as a concern.
Yeah.
Absolutely, I agree.
Have you guys found that when you go to a lab or something, there's big crowds, or are they doing pretty good to try and keep you safe?
So in Canada, where I'm living, Winnipeg, Manitoba, we still are only having what you would say teleconferencing appointments. So mine's upcoming July 20th, and it's via phone. Excuse me, it's still via telephone. So I haven't actually been to any appointments in the hospital since COVID hit. So for Winnipeg, Manitoba in Canada, we're still doing teleconferencing and telephone appointments here.
How about your routine blood tests after your kidney transplant?
So we have a specific, sorry, I should have mentioned that. We have a specific certain amount of clinics that are designated just for blood labs for immunosuppressed individuals that are not anywhere close to or associated with the COVID clinics or testing. So it's very much separated. It's been that way, since everything started, more or less. I mean, they had to get some organization going when this all hit, obviously. When the pandemic came, but that's what we're doing. We have separate clinics for like transplant patients or immunocompromised individuals, which makes me feel very safe because it is a concern. It is a concern of contracting it.
Yeah.
But it makes me feel safe. And for the majority, there was mask wearing there. I know it's a little bit more limited, but typically we'll see more masks in hospitals, or I've witnessed seeing more masks in hospitals or for appointments as opposed to out and about, where now in my city, there's not very many people wearing masks, which worries me. But I mean, to hear you speak of some of these things I think you mentioned individuals who take immunosuppressants have a little more, I'm not sure what you said, stronger.
So they seem to be protected. The thing that often really hurts the COVID patients is there's lots of inflammation in the lungs. And some of the drugs that we use to protect you from a kidney transplant actually reduce inflammation. And so a lot of the organ transplant patients seem to get off pretty lightly.
Interesting.
Pretty good.
So people who are on like a non-prednisone regimen, I know there's some people who after transplant have gone like zero prednisone. They would be more at risk.
So the Prograf and the CellCept also might have some anti-inflammatory effects. And one of their anti-rejection drugs that we're using called tocilizumab or Actemra also has some beneficial effects. So it may not be just the prednisone, but so there was in Bergamo, Italy, there was a huge outbreak of COVID. And the pediatric liver transplant program had about 250 patients. And something like a third of everybody in Bergamo got COVID. The pediatric liver transplant program didn't have a single patient who got sick. Wow. And they knew lots of people got COVID. So the drugs, and even if they're steroid-free, the drugs and being young are protective. There's no guarantee, because there are occasionally people that run into troubles, but it's better than being an adult without immunosuppression, surprisingly enough.
Dr. Grimm, this is Dory. That's interesting that you say that. And, I don't want to veer off the conversation too much, but my daughter has an autoinflammatory syndrome, NOMID, and she's on an IL-1 inhibitor, Kineret. And so she, they've done actually some studies with Kineret and COVID specifically because her body is an inflammatory disease, and the IL-1 inhibitor basically stops the inflammation. But I worry with her because she's a teen, and just veering back to the transition part. When Kayla hears that, she hears then, then I'm okay. And I'm like, no. So what do you have to say to teens who are on that cusp of wanting to be with their friends, and the same with the cystinosis community. Pam. Yeah. I struggle with trying to make sure you stay safe. You are still at risk, but then they hear the saying that some of the immunosuppressants help them, and they want to be out there. So what do you have as far as tips and tricks?
So one of the things that is so unknown is how long this is going to last. As the news is coming out with the surge coming back, and we don't have an obvious vaccine cure in sight yet. Is this going to be 3 months or 6 months or a year or 2 years? And so for young people, their lives are moving on. And so how do they balance it? Well, I do think that young people need socialization, and they need activity, and they need sports. But I think that one of the things you can best do is just wearing a mask all the time, because you're protecting the people around you if you have it, and you're protecting yourself. So wearing a mask is right up there. Washing your hands, not touching your fingers. And then if you do decide to go to school, because school is opening in the fall in a lot of places, or if you're out with some friends, socially distancing, but you're at the same table or whatever, and then someone's got a cold, what do? You don't want to be a jerk about it and say you shouldn't be here because you have a cold. But on the other hand, if that cold is really COVID, you don't want to be around them to pick it up. So you have to sort of think, how are you going to deal with that? And so sometimes rehearsing a few scripts in your mind helps. So if you've said this to a mirror a few times, then it's easier to say it to someone, hey dude, you're coughing, you have a cold. I'm worried about you, Well, are you sure you should be out? What if you pick up something worse? Or I'm going to stay a little farther away at the other end of the table because you're spewing all sorts of nastiness, stuff like that. Or just saying, I don't feel so good. I think I'm going to leave, if you just want to get yourself out of the situation. And practicing how you might deal with those things could be useful, because young people are going to socialize, and giving them tools to make some safe choices will be useful. You can't just say, no, don't do anything. But on the other hand, if they go without masks, if they hang around people who are coughing and sneezing, they do run the risk of getting themselves in trouble. They have to make that decision and balance it out. It's hard because we just don't know when the end will be.
Yeah. Yeah, for sure. So I got a question here for Dory. What are some tips for starting advocacy when transitioning from youth to adult?
So that's a really good question. Tips for starting advocacy when transitioning from youth to adult. For me, it depends on what type of advocacy you might be speaking about. I, for example, think of advocacy twofold. I think of a health type advocacy, and then I think about legislative advocacy, and then I also think about how people get confused between what is advocacy versus what is lobbying. So I'll start with the advocacy versus lobbying because I think that's something that people get confused quite a bit of. We can go back into transitioning from youth to adult for both legislative and health. So advocacy is more the process of stakeholders in making their voice heard that affects their lives and the lives of others on a local, state, and national level. It helps really make policymakers aware of issues that are in general important to people. For example, I can say I am an advocate for rare diseases. So in the general terms, I'm an advocate. But when you lobby, on the other hand, it involves really specific activities that are in direct support or in opposition to a specific piece of introduced legislation. For example, the Cures Act is one that comes to mind that we helped lobby for. However, us as a nonprofit, we can engage. For example, my daughter's nonprofit, we have an auto-inflammatory alliance. That's our nonprofit. We can engage in some forms of lobbying, but the IRS has really strict rules about what portion of budget nonprofit can go towards these activities. So there's also prohibitions of federal funds, for example, for lobbying. So those are the difference with that. So tips and tricks that I would say for advocacy for transition specifically, I think when you think about health transition and what those resources might be, what I really like to go to, there's an organization that has really good tips that we've learned a lot from. I've taken some of those tips and incorporated them into the work that I've done. So for health transition, comprehensive planning, readiness of care, transfer of care, and work off elements that really, really support people with chronic and other disabilities. Another word for another type of advocacy is also for health homes or medical homes. That's important. So when you think about like what are the 6 core elements before, you think about transition, care, and policy, and that's really specifically creating written transition and care policy guides is the first element that I would think about. So something written as far as what you're going to do to transition into adult care. And second, the tracking and monitoring, I would say for that one, you really have to track how you transition your care in a flow sheet. You can do it. There's plenty out there, but there's also EMRs, electronic medical records, that help you do this as well when you track individual transition from youth to adults. So I think those are important. So I think for resources for health, the transition steps that can be outlined, we're going to put a link in the podcast in order for you to see them more clearly. But I really feel like for health, it really starts with age, and it really starts with starting at about 14 or 15, but even as young as 12 to start to transition.
So the first thing, even as young as 12 and 13, is learn about your health condition. Learn what it is, learn how medications work, learn about allergies. Ask your doctor questions that you're not sure of, okay? And also, even at 13, 14, 15, your medical history, you should start carrying your own insurance card. What do you do in case of a health emergency? Who do you call? At 14 and 15, they can start practicing to make their own doctor's appointments and ordering their own prescription refills. That with technology these days, it's getting easier. It could be an app that you can just, this is an app, put it on my phone, I ordered. I'm old school, so I'm the one that picks up the phone. But my daughter on the app just orders it. She doesn't have to talk to anybody. So I think that 14, 15. Even starting a little bit to, when you go to the visit, a little bit of independence, maybe starting to see the doctor alone is an important part of transition. You really have to start to veer in that way, because I feel like that's when it could start giving the person with the rare disease, cystinosis included, the confidence that it's going to take to be able to discuss your own health care. You're going to have to do this for the rest of your life. Definitely at 16, 17, making your own doctor's appointment, seeing them alone, privacy rights, what happens at 18, make a medical summary. As Dr. Grimm said, I took notes and I said, I've not done that. I've talked about it with Kayla, but, she's at the age now, my pet peeve, and this is my mom hat, when I walk into an office, and the nurse on the other end is like, so tell me what tell me what you have, or like the history, and I'm like, oh my God, where do I start? Like, where do I even start? So I like that tip that Dr. Grimm says that we could control that. We can have the outline and say, and Dr. Grimm, feel free to jump in if you have more to say about that at any point.
You're on a roll. You're doing great.
And I said, well, yeah, a medical, like a journey, a medical summary that you can just say, I want to get to the why I'm here. This is my history. And then also talking to your doctor at 16, 17, specifically an appointment about transferring up to an adult care system, and why you want to do that, and how he or she's gonna help in that. So that's important. And then 18 hits, and a lot of families get stuck. There are some families that I work with in the Cystinosis community who are 18 and a half, because of many reasons, but end up with developmental delay. So that does change things with legally, power of attorney, transfer of medical care and the ones they. But once we're 18, if parents are like surprised, you cannot access your kids' medical care unless they give you permission. So I think parents have to be really on top of that and aware. Transitioning to adult care has different layers, because it's one thing to want to transfer to adult care, and the other thing is, for example, my daughter with the rheumatological disease, another thing is there an adult care physician that can take her? I can call my rheumatologist pediatric and make an appointment in a month. When she turns 18 and she calls, well, calling now, right? It could take 2 months for an appointment.
Yeah.
So I think you have to transition carefully, and the transition care timeline for youth and young adults can start as early as 12. And this is on the healthcare side. We can have a whole nother podcast on what happens with sleep transition. Legally for IDA, the law, and 14 and a half is what many states say you start your transition in order to be able to graduate from high school. If you have a developmental delay, you can go up into age 22, and then, by law, you have to have certain things in transition. In the United States, that's what I'm referring to.
So if I could jump in, every state might have different laws, and in Canada it may be different, but in many parts of the world, if you're dealing with your reproductive health, the age is different. And because if you're dealing with sexuality or you're dealing with birth control, you may be able to do that without your parents' consent or knowledge at a much younger age than for other things. So, like, you may need to get their consent if you're going to have a tattoo at age 18, but if you're going to be put on birth control in California, if you're having sex at age 14, the doctors can deal with you on that level without your parents' consent. So it's very variable in different parts of the world. So knowing what the rules are can be useful. And the other thing I wanted to mention was some patients feel like their parents will be angry if they ask for a private visit. So, the parents might be suspicious. What are you talking to the doctor about without me? Or just angry because the parent's been running your healthcare ever since you were 1 year old, and now you're 15 and you want to talk to the doctor by yourself. What's wrong with me? But if you phrase it to the parents like, look, I'm going to have to look after my health sooner or later, and it's like driving a car. Would you want me to just take a car when I turn 16 and go on the freeway? No, you want me to sort of practice on back lanes or parking lots. So what, you come in for a while, mom, in the visit, but maybe you go out for 5 minutes so I can do it private. Or maybe we start with me alone and then you come in and the doctor talks to you about what we discussed. And that way I get practice, just like driving a car. And so sometimes parents, so that kind of something they can relate to, and it's something that a young person can say without feeling that their parents are going to be all suspicious.
Yeah, that's a really good point. Just because as a parent, I feel exactly that. I feel, and not so much suspicious of my situation, just like I want to hear what the answers are. I hear what they say. But to your point, it is absolutely only benefiting them to let them on their own just go in and ask the questions and understand that it's about them. It's a part of life and part of growing up. You know, there's some families that I work with who are, you know, over 20 and their parents are you know, and it's an individual family decision. This is not about judging anyone's journey. Everybody's on a different journey. So I think that's really important to say. You know, some families have that type of relationship. A lot of it is cultural. Even in my own culture, with the families that I work with in the cystinosis community, you know, I definitely try to be in a no judgment zone and put myself in these shoes anytime I help them with any situation, so with transition. You know, I do nudge them when I see that, hey, you know, it's okay. They're going to be okay. You know, just let them go in and whatnot. So I think that's important too. So there are some doctors, and Dr. Grimm, you can talk about this if you want, but there are some physicians who will still see you even if you're 18. I have many.
That's true.
Work with, and there's different policies that hospitals have. Some hospitals say, nope, 18, you're done. Some hospitals say it's up to the doctor. You know, and each hospital has a different policy. You really should find out. I have many patients with cystinosis who still see their pediatric.
Yeah, so it so much depends on the insurance and the healthcare organization. Some mandate at 18 you're done and you have to switch. Others are much more flexible. And the other thing is in people who are developmentally appropriate, it's kind of weird to be going into a pediatric waiting room with SpongeBob and a lot of dolls and Hello Kitty all over the place, and you're like 19, you're thinking, oh, geez. You know, so there's a appropriate growing up and moving on that happens. But there are other people that have something called medicine pediatrics training. So they've done both internal medicine and pediatrics. And so they're really able to sort of help you bridge from pediatrics to the adult world because they've done training on both sides. And if you can get a med peds person, whether they're a primary care doctor or a kidney specialist, they can be your doctor for 30 or 40 years, and there are more of those around. So that's also can be an option sometimes.
I think that's important to note because it does vary with different hospitals and different doctors as well.
Another type of transition from youth to adult is legislative. I think aligning yourself with an organization who specializes in type of legislation and transition is really important. One that comes to mind is rareadvocates.org. They have really, really great tips on how to build a relationship with your congressman, how to reach your congressman, what to say, what not to say. Every Life Foundation is also aligned with that, and they also are the ones that we, as rare disease advocates, that's kind of a go-to when we talk about transition and what we need in order to transition. A lot of it has to do with school and funding and what medical offices might have in tune with what's needed. So hopefully that made sense. For example, A-Lab can become a partner with like the Global Genes in creating an awareness day for cystinosis that's already been created. We know that that's May 7th, but that took a type of advocacy that is unique.
Awesome. Thanks, Dory.
Yeah, thank you.
Very informative. I actually have another question for you, Dory. So currently you're working as a PAM, a patient access manager. First off, can you say a little bit about what that is and how do they or can they assist individuals living with cystinosis?
A PAM, so that's a great question. What is a PAM and what do they help with? A PAM is a unique role in the rare disease world, and different places call them different things. You know, we call them patient access managers, but some are patient advocates. When you need something, your PAM should be right there to help you. And it should be on anything specific to you and anything that surrounds you. So how I look at it is a PAM is somebody who works and helps you with resources, referrals, and really just supports you on your entire journey. Instead of telling you, exactly like a job description, I can give you some examples that I've worked with in the last couple of weeks of things that I've helped families with. For example, I had helped a young man with an application to college since he was going to start in the fall. And due to everything with the pandemic, he was really having a hard time trying to finalize some online classes. So helped him to apply, helped him to find some online classes, and helped him also just to find some funding in order for him to actually pay for the classes. So that's one. I actually was supported a mom find a job online because she has 2 little ones at home. And so she said, you know, I really want to work, but I want to do something that I can do from home because I can't leave, you know, I can't put my kids in daycare and whatnot. So it's not always just about the person who has cystinosis or the person with the rare disease. It's really specifically around like the circle of support. So I helped the mom find a job online that she can stay home and still be around her 2 younger kids. I also helped the family a couple weeks ago work with a nonprofit that walks them through specifically the Social Security system and how to apply for disability. And that was really great just because the mom is Spanish speaking, monolingual, and it's really hard to find Spanish speaking organization and a social worker who was close to her in order to be able to help her to apply for disability and go through the Social Security process, which is really daunting for a lot of families. I helped another family who was laid off and walked through the COBRA process because they were interested in COBRA. And then helped them find an organization who helped them pay for the COBRA as well. I also helped the family with Make-A-Wish. A lot of our families are familiar with Make-A-Wish. I've been a wish granter as a volunteer, apart from being a PAM, for about 17 years. And I help them with the Make-A-Wish process. So just giving you examples because it varies, I guess is the point, that there's support programs out there, and mine is unique because the goal of it is I try to meet the family and the person with the rare disease where they're at, and that's the best way I know to support a family.
If I could come back and do a different job, I'd want to be a PAM. It sounds like you really help in so many ways.
Really satisfying, wonderful experience. I've worked in advocacy, in healthcare, and insurance, in policy, and this kind of brings it all together. So I enjoy it, and I enjoy my families tremendously.
I've learned a lot. I feel like helping someone fill out a college application, that's amazing. Like, I wish I had a PAM myself.
Oh, boy, I know. Yeah.
It's wonderful.
That's what I enjoyed. It's kind of like this you know, it's not like one thing. It's relationship building, navigating healthcare systems. And I am fully from the school of thought is I teach, you know, the teach a man to fish. Like, I really like pointing people in the right direction, but letting them walk through the door. I'll open the door, but you got to walk through it. You know, like I'll say, okay, this is how Make-A-Wish works. This is how it is. Here's the application, but you make the call. You fill out the application, you know, unless they need a little bit more, like some of the younger families that I work with. But even then, so much more. PAM to me is empowering people.
Absolutely, it's almost as though you're the vehicle, but they're the driver.
Yeah, exactly. That's a great way to look at it. So.
Yeah. Mm-hmm. And sort of tying in with this question, it is for you, Dory, but also for you, Dr. Grimm. So myself in Canada, here in Canada, and others with cystinosis in Canada and other parts of the world don't necessarily have that patient access manager, the PAM. So what other types of resources or supports could you think of or come up with that others could use in terms of individuals with cystinosis and their families? So
I think that so much information is present in other patients and families. And if there's one bit of advice I would give, it would be to network, either social media or Facebook or whatever, or in-person visits, or network with other people with the same disease. There's, in addition to the knowledge that these other people have experienced, getting together, you can have safety in numbers and also power in numbers. You can start advocating for your rare disease. So I think that's not necessarily answering your question so much, but because every country is so different, mm-hmm. finding out from other people who've been down that road or a couple of blocks ahead of you on the road is probably the number one thing. What do you think?
So a lot of people that I have supported have connected me to other people in even other countries, in Canada, in Mexico, in Australia, in Europe. And I'm finding that the systems are not set up exactly the same, but there are slivers of information that I've been able to get about support programs for people with rare diseases in other countries. Uritis in Europe has really great training, and now they're moving them online specifically for patients and their families on advocacy, on support, and caregiver support. I really have found that some of their information is really in line with a lot of the goals that we have here. And then there's, for example, Cystinosis Europe. They have Ireland, the UK, Netherlands, France, Spain, Belgium, Italy, Germany, who has very specific outreach for each of those countries for people with cystinosis. So Cystinosis Europe has been a really a good go-to. I've had a couple families who even recently, before the pandemic, were going to travel for an extended amount of time to Europe, and they really wanted to get connected with organizations in Europe in order for them to feel like they had a backup in case something happened. And right away got emails back and that, yes, we'll help them. Here's a doctor that they can see. Here's where they can pick up this medicine in case they need it, if they lose it or they take it from them at the airport, whatever it is. They've been really, really good. Canada, there's CORE, it's a rare disease organization, the Canada Organization for Rare Diseases. I've actually been to Canada with that organization a couple of times a few years back with my other role. And they're growing. I think they look at other models, and they're one of the ones that's starting to grow a little bit more. What I love about some of the Canada organizations, the Live a Little Foundation is another one specific to cystinosis, and raredisorders.ca is that they're really patient and person and family focused. I like how they just completely put the focus on the family. So the opportunities that I've had to work with them have been really, really, eye-opening to me in a really good way. So another country that I worked with more recently, and we actually just had cystinosis conference. I was not able to go due to the pandemic, but they still had it. It was right at the beginning of the pandemic, like the second week of March, and it was Cystinosis Mexico. There's a person there, Victor, who actually had a conference near in the central part of Mexico, had about 20 families and that participated in the conference. And actually, Dr. Grimm participated virtually, and they had other doctors from Mexico participate as well. Femexer.org, FEMEXER.org, is like an overarching rare disease organization, but Cystinosis Mexico actually has their own, and they're starting to get more organized and really starting to be able to connect. Social media, I think, has been a godsend for a lot of these families. That's really the only way they can connect. Facebook groups, some online groups. And so I think they're growing and started to be more organized. And really, it's been really, really interesting to be able to work with Cystinosis Mexico as well.
This is all great advice. I mean, I think other organizations with rare diseases, etc., like CORD, I've heard of them before. The Kidney Foundation of Canada, the Manitoba branch is where I've reached out to and volunteered. Networking, like you said, Dr. Grimm. Nowadays, social media with Facebook groups. These are all awesome ways to resource out. Like, who's the expert of this? Let's find out and reach out. Maybe someone else knows, That's wonderful advice from you. Thank you. Yeah.
Okay, this is a question for both Dory and Grimm. When transitioning from youth to adult while on dialysis, what information do they need to know to advocate for themselves?
Dialysis patients are in a very different situation than most others, because I'm assuming it's hemodialysis, because most people in the U.S. are on hemodialysis. You're going to a dialysis center 3 days a week, and you're seeing other people going to dialysis. And so part of that is, if you're a young person, it's kind of depressing. because most of the people on dialysis are old, 60s, 70s. So, and the number of people who are in their teens or 20s are relatively small. So I think one of the things to remember is that you're not just like everybody else there. Going to dialysis, especially transitioning from a pediatric center to an adult center, can sometimes be a shock just because most of the people are really old. The other thing is the doctors and nurses and social workers are probably just so enthusiastic to see a young person come to their unit because they're used to dealing with these 70-year-old, decrepit, diabetics, and you're different. And so they're actually looking forward to seeing a person and helping them, like with college applications, or helping them find a job, or hearing about your love life or lack thereof. You're going to be fun. So that's one thing to think of, because on a personal level, you're a patient that they're looking forward to. So that's one thing. The other thing is the dialysis doctor may not become your main doctor, because the dialysis doctor sometimes doesn't see you very often, or just like once every 3 months, because most of the time the rounds are made by advanced practice providers. And they may be so swamped by all the dialysis patients, they just don't have any bandwidth for the rest of your body. So when you turn into the adult world, sometimes you have a nephrologist who is a whole body thinker or a holistic doctor, and if so, hold on to that person. But sometimes your holistic doctor might be an internist or a family doctor or a med peds person. So the point I just want to make is, don't limit yourself to think that this dialysis doctor has to be the one that deals with all the other issues. You may have to be creative and be open to the idea that a good generalist, and for women, even a good OB, someone who's sort of a primary care women's health provider, they might be that person that can sort of coordinate care. So that's one of the thoughts.
Thank you, Dr. Grimm. What do you think, Dory?
I think the process in moving patient from pediatric to adult care, it's supposed to be designed to optimize patient health, assist in acquiring independent healthcare skills, prepare for adult model of care, transfer to new providers without disruption. Ideally, this is what should happen, and assist the patients in reaching their full potential when they're going from pediatric to adult, in charge of their own healthcare, ideally. So this does require the healthcare team to have an organized transition to process the patient on this journey, which isn't always the case. So some pediatric hospitals mandate transition at certain ages. Some say 18, some say 21. Some don't have any policy at all. Some states it's also state driven, because some states limit providers licensed for pediatric only. So for effective transition of care, they can promote continuity of developmental and age appropriate care for these individuals, but healthcare teams are not always trained in adult issues, which makes it really hard. Adult-centered care is obviously very different from pediatric care, since the parents are no longer, quote unquote, in charge after their 18th birthday. So what it could mean for the patient, it could be challenging for anyone in general. So imagine being, a young adult confined to dialysis chair, and studies actually have shown that adults appreciate the move forward and growing sense of responsibility if given the right tools to transition. But sometimes feelings of not belonging or feeling useless, it could have the opposite effect, and transition can be even more stressful for the patient and for the caregiver. So what tips that I would say, what they need to know is gradual transition is best, starting as young as age 13. Communication is key. For example, some institutions, larger ones, not all of them, have transition models in place. For example, here in Illinois, Lurie Children's Hospital has a transition program specifically to Northwestern Hospital for youth to adult transition. I have several adult patients, which I think also people do forget that there are adult patients who still see the pediatrician and the pediatric team, especially when they're on dialysis, because they don't want to interrupt that care. And depending on the policy of the hospital, And if it's patient driven, meaning if the patient's okay with it and their healthcare team's okay with it, then make it a happy marriage and they keep going until they feel that it's time to transition, and there's not like a magic age. So I think both doctors and families have to do a better job at boundaries and roles and what happens with transition. Some parents, including myself, are not always so willing to let their young kids take over when it comes to transitioning, especially for something like, at a clinic with dialysis, for example. But learning through your families that I work with, it's absolutely critical for the well-being of the person and the family and the healthcare team, that if the person is ready to transition and is truly able to go into adult care system, then starting as young as possible would be one of the top tips that I would have, and then communication and really outlining what's needed in order for that to happen.
So echoing everything, of course, that Dr. Grimm said, but definitely hang on to those social workers as well within the clinics. I think that's really important.
Yep.
Thank you, Dory. Another question, this one's for you, Dory. How transitioning can affect employment, and some tips and tricks to help explain the employment process?
Employment is such an important part of transitioning to adult care. Most of the families I work with really truly want to obviously live a typical life, which means, graduate from school, they find a job, they can take care of themselves, they can take care of their families. So I think sometimes it's a misnomer that people don't want to do that. So I think it's really important to first recognize that. There is a lot that goes into employment, and I think it actually starts early as well. I think for employment, it has to start as early as high school, and each state is different. Some states, for example, mandate that transition in their school to adult care when a family has an IEP, for example, start at age 14 and a half, and that's here in the United States. Some as late as 16, but I think in that transition plan for work, it has to start earlier, better than later. Workforce commissions are really good places to start with each state, and each state has one. So literally just Googling whatever state you're in, Google workforce transition. They have really, really good tools that I have found individuals can go on there and actually log in and find what resources are in there for their state, what programs they might be eligible for, and what might you be interested. Some of them have job banks that can start really, really young as high school. There's a really good website that we can link. It's called askjan.org/toolkit. It really, really goes into deep employment, general regulations and law as well, because each state is different. And so it's hard to generalize all at once, but each state actually has transition plans already in place. I think for one, if you find a program that you're interested in, reach out to me, reach out to your PAM, and really ask them what steps you need to take in order for your plan to become a fruition, to actually come to life, because each one is going to be different. And I would say for employment, even if it's not specifically with a degree, I think people miscount or not think about really starting off with something like a vocation. I think the vocation programs are growing throughout the country for very specific reasons. I mean, you can get it online and get certified to be, I'm not the techie, but one of my families that I work with taught me is that, oh yeah, I can go online and get Google, I don't know what, you're certified, and now has this great job working as like a programmer or something. I'm like, wow, see, things that I would not think about outside the box. So I think for employment, I think thinking outside the box is important. I think taking the person's skills into consideration is of the utmost importance. And I think also recognizing that there are employment laws that are meant to protect you if you're at work and you are deemed to have a disability, and what that means, and that you are a protected class. And just like when I tell families, you can have a water bottle all day long, Your kid does not have to, does not have to sit there thirsty all day. They can have a water bottle with them. Just put it in the IEP and make sure it's in there. And you'd be surprised. Employers are looking to diversify their workforce. And I think they've made huge strides, although more work to do, in employing people with special health care and chronic needs. I think that's something that even our population, my daughter included, who has a rare disease, I think she worries, well, gosh, am I going to be, like looked at, like, because I have to stop and take my medicine at a certain time and this and that. I think most employers now are really, really aware and conscious of the fact that people with chronic conditions really can add a lot to their workforce, and actually have been shown to work even harder than their counterparts. And that's something that's not talked about a lot. I'll leave you with this. If you Google employment first in your state, it's actually almost like an outline of what employment first is for each state and what it means. It's basically, if your law is an employment first state, which, for example, Illinois is, there's 36 states that are, the rest are working on them, but each of these states has actually employment transition information, and how, if your state is one of those states, it could easily go into their employment first website and link into dozens of resources for online learning, what requirements are for jobs, what it means, what the laws are in that state in order for you to be protected. So if you have time, Google employment first and see what your state has as far as information resource referral. There are some employment myths and facts that I think need to get out there, just because when I work with families, I always find that the myths scare them off sometimes from finding jobs. The myth is accommodating workers with disabilities costs too much. The fact is, in most cases, an appropriate, reasonable accommodation can be made without much difficulty at little or no cost. Studies show that less than 25% of people with chronic conditions require an accommodation, and it usually costs less than $500, if nothing at all. There's also tax incentives for the employers to cover the accessibility costs. Myth number 2, my workers' compensation insurance will go up if I hire with somebody with disability. So many of you may know of a business owner that says, I don't know. The fact is, insurance rates are based on your organization's accident record along with the hazards of the occupation in question. It has nothing to do whether you have people with chronic conditions or disabilities at all. Another myth, the ADA requires businesses to hire unqualified people just because they have a disability. And the fact is, the ADA does not protect unqualified candidates. To be protected from discrimination, candidates must first meet all requirements for a job and be able to perform the job with or without reasonable accommodations. I'll have 2 more myths and facts, and then we'll go from there. Myths. Employees with disabilities or chronic health conditions are often absent. The facts. Studies show that employees with disabilities are not absent any more than employees without chronic conditions or disabilities. So the last one is just a quick one. It says a business can never fire an employee with a disability, even just for cause. That's a myth. The fact. Employers can fire workers with disabilities or chronic health conditions under one of 3 conditions. The termination is unrelated to the chronic condition, the employee does not meet requirements for the job, and the employee poses a direct threat to the health and safety of the workplace. So I think those are important because it kind of outlines specifically a lot of the fears that people have about being employed.
Okay, thank you, Dory. Last question. This is for both of you. In your opinion, what age should the parents let youth help more with their everyday care? Like, for example, medication or say refilling a prescription or doctor visits.
Ooh, well, Dory, you sort of dealt with that. You were giving almost a timeline, so maybe you want to jump in first.
This is a good question, and I'll being a parent as my primary role. I think it's good for me to listen to myself say it because I know I should be doing it. It's not that easy, but I do and have tried. I really feel like at ages 12 and 13, for example, kids can easily learn about their health condition, medications, allergies. They can start to ask their doctor about their health, and also really start to ask, what age are you no longer going to care for me as a young adult? So I think that could start as young as 12, 13. I think a little bit older than that, maybe 14, 15, starting 16. I think you can carry your own health insurance card. You need to learn what to do for your health in case of an emergency. You can practice making doctor's appointments and ordering your own prescription refills by phone, online, or easily through an app, which is something that we've started to do, and it's been great. You can actually start beginning at 14 and 15 to see the doctor alone for part of the transitions doctor visit, and just to help you gain independence in asking questions and managing your health and health care. So I think that's 14, 15. A little bit older, maybe 16, 17, making doctor's appointments, definitely seeing the doctor alone, asking the doctor questions and writing them out ahead of time. Asking the doctor then about your privacy rights when you turn 18. What do my parents have a right to know about or not? You can actually start to make like a medical summary of what you need and keep a copy for yourself, and figure out if you need help making decisions post 16, 17 on to 18. There's a great organization called Family Voices, and they're in every state. They have great resources in order for families to do this type of work. So we can also put another link in the podcast if you're interested in the Family Voices in your area. At 16, 17, you can talk with your parent caregiver about, the age you want to transfer to a new doctor for adult care. And I think post 18 to 21, 22, 23, you're obviously legal adults at 18 and legally responsible for your own care. Parents, including myself, need to understand this and respect that. Your parents cannot or your caregivers cannot access your medical information or be in the doctor's office unless you are okay with it. You can work at this age with your current doctor to find a new adult doctor if needed. Like I said, some pediatricians will keep their, patients until their late 20s. So I have many who do. Make sure you can start to understand how to make sure that your new doctor will accept your health insurance. You can have your doctor transition and work with the adult care team and how to transition your care to that other team that's going to take over if you decide to go strictly to adult care. And so I think other changes will happen at 18. You might be on Social Security and you might not qualify because then you're 18 and you got a job and you make too much money. There's a lot of factors that can take place at that time. So I think most importantly is communication, starting slow, making it gradual, not having everything happen at age 17 when your kid's about to turn 18. I think that's important. But I think, at some point learning to manage your health care, update your medical records, learn how to use MyChart. MyChart is a huge tool that a lot of families, parents don't even know how to use now. And I think even from a young age, give your kids access to the MyChart and look up. I can make everything can be done online, appointments, telehealth appointments, transition, to your adult care team and how to find that doctor in your MyChart and how to ask those questions. And maybe you don't have you don't need an appointment for these conversations. Send a MyChart question to your pediatrician. They'll send right back and say, okay, this is who I might recommend if you want to go to an adult care. Look them up online. How do you find other doctors? My best doctors have come from other moms who said, you know what, there's this doctor that's here. I would not go to anybody else. So how do young adults start to do that as well? So I think there's a lot to learn, but doing it slowly, gradually, and as young as age 12, I think that's going to be setting up for success for both the patient, the parents, and the doctor.
In doing this kind of transition, we have to remember that teenagers and young adults, their brains aren't fully formed until they're probably 25. Heck, I don't even think my brain's fully formed yet. So what happens is some days are really good days, and like an 18-year-old or a 16-year-old might say, I know what I need to do, I'm motivated to do it. But then a couple days later, they may get like a bad exam grade, or their girlfriend might dump them, or they might get into a fight with someone they love, or there's a controversy or something goes wrong. And because your brain isn't fully mature, you kind of forget what you promised, or you forget that you were going to take all the responsibility for your meds. So I think it's important to always have backups, safety nets. So if the teenager has decided, okay, I'm going to be responsible for my meds, make sure there's a safety net. And here's an example. Don't ever just have all your meds in the bottles, because if you forget in the morning, you have no way of knowing it. Put at least some of your meds in one of those weekly medication boxes, you know, where it's like there's a little box for Tuesday morning and Tuesday night and Wednesday morning and Wednesday night. Put at least some of your meds there. Maybe not your Prosis because you need a giant box for it, but all the others. So that if you forget, it tells you, because you come back in the afternoon and you think, oh, damn, I still have my morning meds in there. So you get feedback. And maybe you've got a parent or an older brother who will sort of tiptoe into your bathroom where you keep your medication box and just check. And if they see Tuesday morning meds are still in the box and you're heading out to school, you know, they might say, hey, you know, you still got your morning meds here, so should we drive them to school for you, or something like that. So that's just one example of having a safety net, so that you're just not all of a sudden on your own, because we know we all make mistakes. As we're humans, we're all growing to try and get better, and so that's important.
That was the questions we had from the community. Is there anything you or Dory would like to add?
Go ahead, Dr.
Lord, we've had a pretty far-ranging discussion. I found that this was a lot of fun, and it was interesting to see what questions were prioritized. If you ever got another stack of questions, again, I'd be happy to come back, maybe with Dory. I know I'll volunteer Dory, right?
Yeah, you're voluntold. Yeah, we definitely would love to have you guys both back on as we're future planning more episodes. You've shared a lot of such important information, guidance, support, tips for youth or young adults, or even myself, in terms of learning what a PAM is, and just kind of hearing about what other resources, and Dr. Graham, as you mentioned, networking.
Cheryl, I still think of you as a young adult.
Yeah. Probably still think of me as a kid.
No.
Okay. Dory, I don't know if you know, but I actually knew Dr. Grimm, and I was, how old was I, Dr. Grimm? 7, I think? He was my doctor?
About 7. Yeah. You know.
So 7.
25, how is that possible?
There you go. I'm much older than I look.
What I want to say is it does boil down to relationships, and it does boil down to trust, and it does boil down to transition is really a journey, and every parent and every child and every family unit, because it's not always parents, it's foster parents, caregivers, the grandparents taking care of kids, and I think it's important to support the family with it where they're at, but nudge them along enough to say it's needed. You know, if everything goes as the universe, who knows this after this year, right? But if everything goes how the universe says it's going to go, you know, we're going to be gone before our kids. So I think it only serves them well, tools to empower them starting at an early age. You know, I really am grateful to A-Lab for having this discussion. So I want to say thank you to all of you. Thank you to Dr. Grimm. I feel like I'm going to share this with my network as well, because I think it's well relevant to the rare disease community. Thank you.
Absolutely.
Yeah, and with that, we would like to thank the Cystinosis Research Network for sponsoring us and for making this podcast possible. And also a big thank you to our guests, Dr. Paul Grimm and Dory Riviera, for joining us today. What has been discussed on this podcast is the professional opinion of Dr. Grimm and Dori Riviera, has expressed only her own opinions and not that of Horizon Pharmaceuticals. And please look for our next podcast, Cystinosis and Bullying. And we will have those links up on our podcast at a later date.
Thank you, guys.
It was a lot of fun. Thank you so much for inviting us. I had a great time.
Thank you.
Thank you.
For being here.
Thanks, guys.
Bye.
Take care. Take care. Bye.
Bye.